On behalf of Oncologic Academic Forum, I'm Dr. Siddharth, inviting you all for today's session on anti-EGFR therapy in locally advanced head and neck squamous cell carcinoma by Dr. Cessal, Thommachan, Kainickal, Additional Professor, Head and Neck Oncology, Regional Cancer Center, Thiruvananthapuram. Over to you, sir.
Thank you very much for the kind invitation. Can you close the this one with sharing? Can you stop sharing your screen? Okay, thank you very much. I will share my screen. I have some issues with my presentation, this PPT. There is some issue with my Microsoft because I've prepared in my desktop, but now I am using my Google, this one, Google Slides. So I do not know whether it will be, can you see that?
Yes, sir.
Okay, thank you. So today we will be discussing about the role of anti-EGFR therapy in locally advanced squamous cell carcinoma. Mainly we'll be discussing the definitive treatment, like what is the role of anti-EGFR therapy when you use radiotherapy as a definitive treatment. Then if time permits, we'll discuss the role in adjuvant setting as well. Then we will not be discussing the role in the recurrent or metastatic disease because we will not get much time to discuss that. We know that the role of the main treatment for a locally advanced disease is if you're planning for a non-surgical treatment, mainly in oropharyngeal carcinoma, larynx or hypopharynx with an intact cartilage and function, and selected oral cancers in gingivobuccal complex tumors, the standard treatment is to consider a radiotherapy plus systemic treatment. In patients who have oral cavity disease, larynx or hypopharynx with cartilage destruction, generally they are treated by surgery followed by post-op radiation. So we believe that the primary goal of any treatment in head and neck cancer is to have a good locoregional control. The locoregional control is presumed to translate into an overall survival and better disease-free survival. So in this context, we will be discussing what is there in a role for anti-EGFR therapy in locally advanced squamous cell carcinoma. We will not discuss the nasopharyngeal carcinoma because that's a different disease. We will be discussing the HPV positive oropharyngeal carcinoma also. So the locally advanced squamous cell carcinoma constitutes around 60 to 70% of the cancer burden on head and neck squamous cell carcinomas because majority present at advanced disease. We may have to use all our weapons to tackle the disease. Patients with stage 3 and stage 4A. Stage 3 is with patients who have T3 disease or patients with N1 disease. This is applicable for oral cavity, oropharynx, larynx, and hypopharynx, which is HPV negative. HPV positive C oropharyngeal carcinoma is a separate disease. So that we'll discuss as a different entity. Stage 4A disease is T4A disease or entity. So in patients with stage 3 and stage 4A, our intensity is to have a good locoregional control and good survival. And aim is cure with the either as I have discussed the treatment modalities. In patients with N3 disease or T4B disease, in selected patients, we will go for radical approach. In selected patients, suppose a patient is having a young patient, good performance status, small primary with N3 disease, or a T4B disease with a good low volume disease, young patient with low nodal disease, they are treated with a radical. In general, they are treated with a palliative approach. So the treatment of a locally advanced disease, stage 3 and stage 4A, the main treatment is up to 70 years and patients who have performance status 1. The treatment is to consider radiotherapy forms the backbone of the treatment in oropharyngeal carcinoma, larynx and hypopharynx with intact and functional larynx. And in other situations like advanced tongue tumors, patients who have larynx or hypopharynx with dysfunction, advanced disease, or with cartilage destruction, they are treated by surgery followed by post-op radiation. This is a planned treatment. Surgery followed by post-op radiation is a planned treatment. In last class, we discussed about the management of oral cancer. So we discussed about surgery followed by adjuvant treatment. Now, coming to the anti-EGFR therapy in head and neck squamous cell carcinoma, how the EGFR pathway is functions. That's the first and foremost thing that we'll look. In almost 90% of the head and neck squamous cell carcinomas express EGFR. So what happens with these are EGFR receptors. This is an extra. This is the cell membrane. This is cell membrane. So you have an extracellular domain and intracellular domain for the EGFR. This is a receptor. Now you have, there are certain specific receptor ligands like EGF. When they bind together, and the functional unit which occurs into the homodimerization or heterodimerization of the EGFR receptors. This is the EGFR receptor. Then the others are HER2, HER3, HER4, and HER3. These are the receptors. So when EGFR and EGFR, this dimerization is homodimerization. And any of these two together, dimerization is called heterodimerization. So the activation of this dimerization will lead on to the formulation of functional active homodimerization, homodimer or heterodimer. And this will lead on to an ATP-dependent phosphorylation of the specific tyrosine residues. So this is the ATP-dependent phosphorylation of the specific tyrosine residues of us. And this is the active step. From there, two pathways get activated. And the two pathways are, one is the RAS, RAF, MEK, and MAP kinase pathway. And this is the pathway which is involved in the transcription and the progression of the cell cycle from G1 to S phase. So this will lead on to cell proliferation when this pathway is activated. The second pathway is the PI3K kinase AKT pathway. And this is when this pathway is activated, the anti-apoptotic signals are generated. So this will lead on to cell cycle proliferation, invasion, metastasis, and tumor-induced neoangiogenesis. So what does the EGFR receptors do? Anti-EGFR receptor antagonists do. So this can be monoclonal antibodies. This monoclonal antibodies acts in the extracellular domain. So what does it houses? It prevents the homodimerization, and this will lead on to active phosphorylation of the tyrosine residues. And this pathway is inactivated. The second mechanism is to use an intracellular tyrosine kinase inhibitors, TKI, like geftinib, erlotinib. So they will inhibit this phosphorylation. So this will lead on to the pathway activation. So the most of the data in the phase 3 setting is with monoclonal antibodies. The TKIs, that is geftinib, erlotinib, and this data, or this lapatinib, mainly the data is confined to the phase 2 data in locally advanced. We have data for lapatinib in stage 3, but in adjuvant setting, but in definitive setting, the data is mainly confined to the phase 2. Yes. Now coming to the next, another action. So when this antibody acts, this will lead on to inhibition of the cancer cell proliferation, invasion, metastasis, and tumor-induced neoangiogenesis. And the induction of the cancer cell cycle, arrest, and potentiation of the anti-tumor activity of the cytotoxic drugs and radiotherapy. Now, another action is the activation antibody-dependent mediated cytotoxicity. And so this is the anti-EGFR degradation occurs. So this is the main activity of the EGFR, anti-EGFR drugs. So I think you can see my slides. Am I right?
Yes, sir. The slides are visible.
Okay, thank you. So I'll be discussing mainly the phase 3 trials, because this anti-EGFR therapy can come as a short note, or it can even, so for this, what are the ways by which this has been tested? One, what is the role of anti-EGFR drugs in addition to radical radiotherapy in the definitive setting? I will be discussing only the definitive setting, because due to the scarcity of time, if time permits, we will discuss the adjuvant setting, or I will take it as a question and answer. So now, what is the role of anti-EGFR drug in addition to definitive radiotherapy? Second is, we know that the concurrent chemoradiation is the present standard. What is the role of concurrent chemo in addition to the concurrent chemoradiation? What is the role of adding an anti-EGFR monoclonal antibody? Third is, can we replace? This is a radiotherapy plus cetuximab basis. So what is the role of chemotherapy? Suppose if you plan a cetuximab plus radiation as a standard, what is the role of addition of chemotherapy in addition to the radiation plus cetuximab. The fourth attempt is, can we replace the cisplatin with an anti-EGFR drug? So that is the fourth. And the fifth one is, if you give induction chemotherapy in the form of PPF, can we use cetuximab plus radiation in the concurrent fashion versus the standard concurrent chemoradiation? So these are the five approaches which we have used or which have been tried in various phase 3 trials to know the efficacy of anti-EGFR drugs in locally advanced squamous cell carcinoma. The first is the use of cetuximab. That is, what is the role of cetuximab in addition to radical radiotherapy? So this was a Bonnet trial. We all know this study, which was published in New England Journal of Medicine in 2006, in February 9, to be specific. Then, to be precise, then in 2006, and this was a randomized trial comparing radiotherapy versus radiotherapy plus cetuximab. Radiotherapy was given a radical dose, and this was given as conventional, altered, or the axial radiotherapy, or two forms of axial radiotherapy, versus the cetuximab, which was given 400 milligram per meter square, 1 week prior to the start of radiation, and 250 milligram per meter square of weekly cetuximab till the completion of radiotherapy. And the data was updated in Lancet Oncology in 2010 in April issue with a 5-year research. So first we will discuss. So this was a phase 3 trial, radiotherapy, and that was not versus the concurrent chemotherapy. It was radiotherapy versus radiotherapy with cetuximab. And this was stratified by the Kainickal performance status, regional nodes, stage, radical radiotherapy fractionation. And then when the data was initially published in New England Journal of Medicine in 2006, with a median follow-up of 54 months, it was found that locoregional control, which was a primary endpoint of the study, the patients who received cetuximab had 24.4 months versus 14.9 months with a quite statistically significant p-value. This was same for overall survival, 49 months versus 23.3 months, the p-value was significant. And this was the median follow-up was 54 months. And their data was updated in 2010 with a 5-year result. And the two important findings, it was found that there was almost a 9.2% increase in 5-year survival in patients who received cetuximab compared to radiotherapy alone. The p-value was significant, and the benefit was mainly if there was a rash, prominent rash, there was rash, those who have rash from grade 2-4 compared to a 0 or grade 1, there was a statistically significant improvement in 5-year survival. And this was two important findings from the update. And they have done a subset analysis, but this was not a planned, this was an unplanned subset analysis. And the patients who benefited from this, the cetuximab compared to radiotherapy alone, was patients with T1 to T3 disease, patients who were treated in the USA, patients who had received concomitant boost radiotherapy, and oropharyngeal patients with good performance status, males, and these were the patients who had oropharyngeal findings. Yes, the patients who were treated with oropharyngeal findings. So these were the subset of patients who benefited, but this was not a planned subset analysis. So if you look into the toxicity, what is the added toxicity in addition to radical radiotherapy alone was, this was mainly for the skin reaction. The skin reaction was more in patients who received cetuximab, and also infusion reaction were more in patients who received cetuximab in addition to radical compared to radical radiotherapy alone. And this publication was with a good editorial by the Marshall Osner, who was the PI of the TAX 3-4 trial. And how he concluded in the editorial was, at present, for patients who can tolerate it, chemoradiotherapy with cisplatin remains the standard of care, because it was not with the radiotherapy plus cetuximab versus concurrent chemoradiation. It was radiotherapy versus radiotherapy plus cetuximab. So concurrent chemoradiation was not an arm. So the second is, so what is this? So we know that the concurrent chemoradiation is the standard of care. The Bonnet trial was activated in before the publication of the McKenzie meta-analysis published in Lancet in 2000. So that is why they have used the radiotherapy basis radiotherapy plus a monoclonal antibody. And the second attempt was to give, is there any benefit by adding a monoclonal antibody in addition to the standard concurrent chemoradiation? The concurrent chemoradiation is the standard treatment, and the maximum benefit is seen in patients who are receiving chemotherapy in addition to radiation in the concurrent fashion, based on the McKenzie meta-analysis initially published in Lancet in 2000, then updated in Green Journal in 2009. And there was an update which was presented in ESMO annual meeting in 2016. Those who are interested who can read this, there's an update. There's a recent update has been recently published in Green Journal in January in 2021. So those who are interested just can Google that. So this is freely, you can download it freely. And it shows that the 5-year benefit, if you add a chemotherapy in addition to radiation, the concomitant, the benefit is 6.5% at 5 years. And it is 3.6% at 10 years. And then is there any benefit by adding a monoclonal antibody in addition to that? And the McKenzie meta-analysis, if you the conclusion is that the single agent is equivalent to multiple agents. The maximum benefit is seen in patients with young patients. As the age advances, the magnitude of benefit comes down. The benefit is mainly seen in patients who have performance status 0 or 1. Patients who have PS2 or more than 70 years, the magnitude of benefit is very low. So that was the conclusion. So now the question in anti-EGFR therapies, is there any benefit by adding? So there are 3 studies which evaluating this. One is the RTOG-0522 clinical trial. This is incorporating a cetuximab in addition to concurrent chemoradiation. This is a large trial including 900 patients. Another trial from the TMH from India, this is addition of nimacimab to chemoradiation. This also included more than 500 patients. And the third trial was the DAHNCA 19 clinical trial. And the first 2 trials have presented and published. And third trial, the DAHNCA, this was a negative trial. And there was the addition of salutamab in addition to chemoradiation. This was presented in the multidisciplinary head and neck symposium in 2014. And this, to best of my knowledge, this has not been published. So first, we will discuss the RTOG-0522 clinical trial. And this includes 940 patients. The primary endpoint was progression-free survival. The patients were randomized to receive concurrent chemoradiation plus cetuximab basis. The control arm was concurrent chemoradiation. And the experimental arm was concurrent chemoradiation plus cetuximab. Same chemoradiation regime plus cetuximab, again 400 milligram per meter square given 1 week prior to start of radiotherapy. And it was given along with radiation with a dose of 250 milligram per meter square. Then it was followed up. The primary endpoint was progression-free survival. The data was published. Initially, it was presented in ASCO annual meeting in 2011 by Professor Kainickal and published in JCO in 2014 with a median follow-up of 3.8 years. It was found that the progression-free survival, this was the endpoint. There is no benefit. P-value was 0.63 at progression-free survival was 61.2% versus 58.9%. There is no difference in the outcomes. And this was same in terms of overall survival or locoregional failure or distant metastasis. There was no benefit. But what about the toxicity? There was an increase in toxicity in patients who received cetuximab in addition to concurrent chemoradiation in terms of the radiation mucositis, skin reaction, and skin reaction inside and outside the portal. And also patients had electrolyte imbalance in the form of hypothermia. So the conclusion is, and also in patients with anorexia was better, more in patients who received cetuximab. So the conclusion is that if you add a cetuximab in addition to concurrent chemoradiation, there is no benefit in terms of progression-free survival, overall survival, or there is a reduction in distant metastasis. But there is a 10% increase in grade 3 and grade 4 toxicity. The conclusion is that there is no benefit. Now, the second trial is the salutamab trial. That is the advanced head and neck squamous cell carcinoma patients, around 600 patients. The primary endpoint was locoregional control. And this is an accelerated radiotherapy. We know that in DAHNCA, they follow the 6 fractions per week. That is 66 to 68 gray. And it was given 2 gray per fraction, 6 fractions a week with the hypoxic radiosensitizer nimerazole plus CDDP, that is weekly cisplatin 40 milligram per meter square. That is the control arm. Then the experimental arm was adding enzalutamide 8 milligram per kg once in 3 weeks. And this was the experimental arm. And the data was presented by Eriksson from the Denmark. And he presented in the ASCO Head and Neck Symposium in 2014 with a median follow-up of 36 months. There is no difference in locoregional control between the two arms, 78 versus 79, and there is a 29% increase in grade 3 and grade 4 rash. So, and to best of my knowledge, this paper has not been published. To be very honest, I request if anyone have come across with the publication of this paper, please inform me. Now, third paper is the TMH paper. So this is the concurrent chemoradiation versus concurrent chemoradiation plus nimesulide. Around 536 patients were randomized to concurrent chemoradiation, that is 66 to 70 gray plus 33 to 35 fractions of radiotherapy, plus in all of the trials, they used 100 milligram per meter square or weekly 40 milligram per meter square. Here, the TMH used 30 milligram per meter square weekly, and the nimesulide dose was 200 milligram flat dose every weekly till the completion of radiotherapy. This study was presented by Dr. Vijay Patil in ASCO annual meeting in 2018 and published in Cancer in the next year in 2019. And with a median follow-up of 39 months, the progression-free survival was the primary endpoint. And this 2-year progression-free survival was 61.8% in patients who received nimesulide compared to 50.1% in patients who received chemoradiation. This is better, and locoregional control was also better in patients who received nimesulide compared to chemoradiation. But there was no improvement in overall survival. The trend was, there was a trend, and the p-value was 0.08. The hazard ratio was 0.84, but this was not, the p-value was this was not statistically significant. There was no overall survival benefit in this particular trial. And there was 11% increase in radiation mucositis in patients who received nimesulide compared to chemoradiation. So the conclusion is that there is an improvement in progression-free survival. There is an improvement in locoregional control. There is no improvement. There is no improvement in overall survival. It's an increase in toxicity. And they have done a subset analysis, but this was not a planned subset analysis in 187 patients. And there was an improvement in progression-free survival. There was an improvement in overall survival without improvement in disease-free survival. The data was published in OncoTarget in 2020, January. So the conclusion from the 3 studies is that none of the trials did not show any survival benefit. The RTOG0522, the salutamab trial, or the TMH trial did not show any survival benefit. There is an increase in toxicity across the board, and there was the TMH trial showed an improvement in progression-free survival. And for me, we need more robust data to accept this as the standard, in addition to the standard chemoradiation. Yes. So next is if we consider the cetuximab plus radiation as a standard, although it is not a standard, but the GOTEC group thought that this can maybe considered as a standard treatment because the RTOG, the Bonner trial have shown that cetuximab in addition to radiotherapy has shown an improvement in survival. So this was they did 2 trials in parallel. So one is called the GOTEC 2007-01 clinical trial. Another is 2007-02 clinical trial. So we'll discuss both trials. In the 01 trial, 2007-01 clinical trial, and what they have done was they included chemotherapy in addition to cisplatin plus radiotherapy. So cisplatin plus radiotherapy was the control arm. The chemotherapy plus cetuximab plus radiation was the experimental arm. And this included 400 patients. Only N2 patients were included. They have done the 2007-02 clinical trial was mainly for advanced disease like N2C or N3 patients. So what the primary endpoint was progression-free survival, 3-year progression-free survival. When the data was published in JCO in 2018, both the 2007-01 and 2007. O2 clinical trial was published in JCU in 2018. And the 3-year progression-free survival was better in patients who received chemotherapy in addition to sepsis plus radiation. So the chemotherapy was given was carboplatin plus 5-fluorouracil. So these two, so we cannot omit. So we cannot say that cetuximab plus radiation is the standard. There was a almost 12% increase in 3-year progression-free survival, which was the primary endpoint, with a median follow-up of 4.4 years, although there was no improvement in overall survival. So when they analyzed the cumulative, the failures, it was found that the locoregional failures were less in patients who received chemotherapy in addition to the cetuximab plus radiation. And this was the hazard ratio for locoregional controllers 0.54 in favoring chemotherapy in addition to a monoclonal antibody plus radiotherapy. And there was no difference in distant metastasis. Now, what about the toxin? And the chemotherapy arm had a better increase in toxicity compared to patients who received a monoclonal antibody plus radiotherapy. Now, the fourth question is, can we replace cisplatin with a monoclonal antibody along with radiation? So for all patients together, there are 2 studies that is called ARTScan 3 clinical trial, very recently published last year, 2020 JCO. And the HN6, that's by the National Cancer Institute Canada study, HN6 trial, and with panitumumab. This trial is with cetuximab, and this trial is with panitumumab. So the ARTScan 3 trial, this study was done in Sweden. It's a randomized phase 3 trial comparing the standard chemoradiotherapy with cisplatin versus cetuximab. And so you give radiotherapy. It was 70 gray, 66 to, there is 68 gray radiotherapy versus weekly cisplatin, 40 milligram per meter square, versus the same radiotherapy plus weekly cetuximab. So can we replace cisplatin with cetuximab in all patients together? So almost 300 patients were randomized. The primary endpoint of this study was overall survival. For T3 and T4 patients, there was a secondary randomization for comparing 68 gray versus 73.1 gray radiotherapy. There was an escalation of dose in primary tumors who have advanced primary, is there any benefit? So when they published the results, the 3-year results was published in JCO in 2020, and 3-year overall survival, there was a 10% difference in patients who received between cisplatin and cetuximab, favoring cisplatin. And this was also, if you look into the failures, the failures were less in patients who received cisplatin compared to cetuximab. It was 23% versus 9%. So the failure were more in patients who received cetuximab compared to cisplatin. And this study, the data independent monitoring committee said, it is high time to stop the trial because it showed there is a 10% difference in survival. And the study was prematurely closed. Actually, they were planning to approve, the target was 604 patients. The study was prematurely closed and published in JCO in 2000. Now, in patients, if you look into, there was a difference in toxicity profile. This is interesting. If you look into patients who received cetuximab, the mucositis, skin reactions, and rash, these were more in patients who received cetuximab. But if you look into the cisplatin, the hearing, mainly the neutropenia, the tinnitus, ototoxicity, the nausea, vomiting, and the acute. So it is mainly the standard toxicities of cisplatin, nausea, vomiting, the renal toxicity, then the ototoxicity, and the hematological toxicity were more in patients who received cisplatin. And second is the panitumumab trial. The panitumumab trial is the HN6 trial, and this was a trial comparing the concurrent cisplatin, and this is concurrent radiotherapy was given 70 gray, 35 fractions, that is 2 gray per fraction, 5 fractions a week, 7 weeks, plus cisplatin, high dose, 100 milligram per meter square. That is the control arm. The experimental arm, they used accelerated radiotherapy instead of conventional fractions radiation. So they used the same 70 gray in 35 fractions, That's 6 fractions a week. So that was 6 within the treatment complete in 6 weeks, plus panitumab. It's 9 milligram per kg. That was given every 3 weeks for 3 cycles. So that was the design of the trial. The primary endpoint was progression-free survival. 326 patients were enrolled in the trial. The data was published in JAMA in 2017. And earlier they have conducted trials with phase 2 trial. The Concert 1 and Concert 2 trials were published in Lancet Oncology in 2015. And the Concert 1 is there the chemoradiotherapy plus panitumab. And Concert 2 was, can we replace the cisplatin with the panitumab? The same design, more or less same design. And both were negative trials. And the phase 3 trial, with a median follow-up of 46 months data published in JAMA in 2017 showed 2-year results, either in progression-free survival, which was the endpoint, primary endpoint, or the overall survival. There was no difference between the outcomes. And the toxicity was similar. That I have seen with the previous trial. Now, so we have discussed 2 studies, that is the panitumab trial and also the ART-SCAN in with concurrent chemotherapy. These all patients were clubbed together. And in HPV positive patients, there are 2 studies, de-escalate and RTOG 1016. And both published in Lancet in 2016. The RTOG 1016 study was presented in ASTRO annual meeting in 2018 and published in 2019 Lancet. And first we will discuss the de-escalate trial. The de-escalate trial, which was done in UK by the Hashim Mahana group on behalf of the de-escalate HPV trial group. And it was include only low risk patients. So we knew that the HPV positive patients include the low risk and the intermediate risk based on the risk stratification was done in a landmark paper published in EGFR in 2010 by Professor Kainickal based on a subset analysis of the RTOG 0129. So low risk patients were 348 patients. Number of patients were less compared to the RTOG 1016. They were randomized either to give cisplatin plus radiotherapy or cetuximab plus radiotherapy. And the primary endpoint was toxicity. And there was no difference in toxicity. There was no difference in toxicity between the 2 arms. But at a median follow-up of 22 months, it was found that 2-year overall survival and in terms of recurrence, the benefit was mainly, it is seen, let's say, cisplatin compared to cetuximab. And it shows that there is an improvement in survival with cisplatin compared to cetuximab. So we cannot replace cetuximab, cisplatin in HPV positive disease. So they have a good prognosis. There is no difference in toxicity between the 2 arms, better overall survival and less recurrence with CDDP plus RT. So radiotherapy plus cisplatin remains the standard of care even in low-risk HPV positive disease. That was the conclusion from the de-escalate. When we look into the RTOG 106, there's a large trial included around 900 patients, 987 patients. The number of patients were almost 3 times compared to the de-escalate trial. It included the low-risk and intermediate patients also. And the primary endpoint was overall survival. The primary endpoint of de-escalate was toxicity. Primary endpoint of RTOG 1016 was the overall survival. And it was a non-inferiority trial. So can we give the same efficacy with cetuximab plus radiation compared to the cisplatin plus radiation? So as we have seen with the other trial, the ART-SCAN 3 trial, there is a difference in toxicity profile in these patients also. The mucositis, so you can see that the rash, dermatitis and rash were more in patients who received cetuximab. There's no difference in toxicity in terms of mucositis. But the other toxicities like the vomiting, the nausea, the renal toxicity, the hearing impairment were all more, all were more in patients who received cisplatin as expected. And with a median follow-up of 4.5 years, which is having a long-term follow-up compared to the de-escalate, the median follow-up of de-escalate is 22 months. Here it is more than almost 5 years, 4.5 years. The 5-year overall survival were better in patients who received cisplatin compared to the cetuximab, and the inferiority margin was not attained. So this table compares between these two trials. So the conclusion is that we cannot replace a monoclonal antibody in addition to, we cannot replace monoclonal antibody with cisplatin. So we cannot replace a monoclonal antibody, cisplatin with a monoclonal antibody in patients who have HPV positive disease. And there is another trial which is ongoing, TROG12 clinical trial in Australia and New Zealand. And this is also looking into this particular question. And this is that we do not have results on that. So the other approach is, can we give the induction chemotherapy with TPF? You give TPF as induction chemotherapy. Then along with radiation, you give cetuximab compared to the standard concurrent chemotherapy. So this is whether this is a good approach. So this is the Kainickal 2007 O2 clinical trial. Yes, then so the primary endpoint of this trial is a progression-free survival. It includes only N2 and N3 patients. It was like a DECIDE trial, if you, those who remember the DECIDE trial, which was like comparing TPF followed by chemoradiation versus chemoradiation for N2 or N3 disease. That's a DECIDE trial, similar to that in Kainickal 2007 O2 clinical trial. So what they have done was they give TPF 3 cycles, then you give cetuximab plus radiation, versus you give chemoradiation. That is the standard Kainickal chemoradiation program is to give carboplatin plus 5-fluorouracil acid plus radiotherapy. So the primary endpoint was progression-free survival. Almost 370 patients were included in the trial. Now, when they analyzed the results with a median follow-up of 2008 years, and this was published in JCO in 2018, any of the parameters, the progression-free survival, locoregional control, overall survival, there was no difference in the outcomes. But there was a borderline significance in patients who received TPF for borderline significance. The p-value was 0.085 for distal metastasis-free survival. So toxicity was more in patients who received TPF compared to this one in terms of fever. The neutropenia were more in patients who received chemo prior to the chemoradiation. Now, when we conclude, I'm coming to the last part of my talk. So this radiotherapy versus radiotherapy plus a monoclonal antibody, that is radiotherapy versus radiotherapy plus cetuximab. There is increase in overall survival. There is increase in locoregional control. And the benefit was this, that was the Bonnet trial. There is an increase in toxicity. When we compare the concurrent chemo, is there any benefit by adding a monoclonal antibody in addition to the standard concurrent chemoradiation? 3 studies, that is the one is the RTG0522, no survival benefit, no progression-free survival benefit, increase in grade 3 and grade 4 toxicity, 10%. The Salitumab trial, again, there is a negative. In addition to chemoradiation, there is a 29% increase in grade 3 and grade 4 rash. And the TMH trial, there is an increase in improvement in progression-free survival, DFS benefit, no improvement in overall survival. There is an 11% increase in mucositis. So there is a locoregional control and PFS benefit in one study. None of the trials showed an improvement in overall survival. Is there any benefit by adding chemotherapy in addition to the cetuximab plus radiation? That is the Kainickal trial. So they just showed there is benefit. That is the 2007-01 clinical trial. Now, can we replace a cisplatin with a monoclonal antibody? 2 studies, the ARTScan 3 and the HN6, both showed no benefit. And ARTScan was prematurely closed. Panitumab study was a negative trial. And in HPV positive disease, we cannot de-intensify by using a monoclonal antibody. Cisplatin is an integral part of treatment. Now the question is there any benefit by adding induction chemo followed by RT plus cetuximab basis concurrent chemoradiation? Again, we have just seen the Kainickal 2007-01 clinical trial. Again, there is no benefit. So that is the conclusion. Now, if you are interested, there are 2 meta-analyses. I'm not going into the details because both the meta-analysis did not show any benefit So this is one published in Oral Oncology in 2014 by the Italian group, other by the Korean group that published in 2017. And both showed that cisplatin plus radiation remains the standard of care. Now I have a few questions, and before I conclude, I will take an induction system. Okay, I will take up that the adjuvant cetuximab. I will take up that. Yes, wait, I will take up that. Okay, then so this is so if you are interested to have the slides, then please email me, or this is my WhatsApp number. So you please email me. I'm ready to send the slides. I'm ready to take a few questions. Yes, any role for induction? Induction, there is no hardcore data to say that we have hardcore data to say that. Okay, well, I will take one. The adjuvant cetuximab. Okay, first I will discuss the adjuvant cetuximab. There was a phase 2 trial, the RTOG0234 clinical trial, and it did not show much benefit. And if you look into the high risk patients and intermediate risk patients, in high risk patients there are two studies that comes to my mind. One is the lapatinib trial by Professor Kevin Harrington. This was a randomized. We are also part of that trial. That was a phase 3 trial comparing the concurrent chemoradiation plus lapatinib versus concurrent chemoradiation in the adjuvant setting in patients who have the margin close, margin positive, or extracapsular extension. And the patients were given standard 60 to 66 gray post-op radiation plus cisplatin and lapatinib concurrent and maintenance lapatinib for 1 year. And the data was presented in ASCO annual meeting in 2014 and presented in JCO in 2015. Primary endpoint was disease-free survival, and there was no benefit. And second is nimistumab trial, where we are also part of that. And this is a Singapore Cancer Center initiative trial that is comparing high-risk patients are randomized postoperatively to chemoradiation adjuvant setting plus concurrent nimistumab, and no adjuvant nimistumab. So there is no maintenance. And so this is an ongoing trial, and the approval has been completed. We are awaiting the results. Regarding the intermediate risk patients, there is an study called the RTOG0920 clinical trial. I understand that the study the approval is complete. In those patients who do not have margin positivity or extracapsular extension, that is T3, T4 disease, multiple node positive disease, PNI, LVSI patients, or even T3 patients with a depth of invasion more than 5 mm were randomized to give post-op radiation or post-op radiation plus cetuximab, RTOG0920 clinical trial. And we may have some preliminary results in year or two by 2022 or 2023. So we'll have some preliminary results. So that is in the adjuvant setting. Neoadjuvant, we do not have any hardcore data. We use a monoclonal antibody apart from chemo. Yes, I will take up the chat box. Okay, that's what's. Is there a situation which you consider cetuximab to standard despite negative evidence? No, never. Okay, there is no data to use. It will be more toxic, and we will never consider. So in my practice, if patient can tolerate, cisplatin plus radical radiotherapy is the standard. If a patient cannot tolerate cisplatin by any means, like poor GC, and patient have a renal impairment, then you may consider cetuximab in addition. Cetuximab, which head and neck site has the maximum benefit? So if you ask me, the maximum benefit was seen again from the Bonner trial. It was an unplanned subset analysis. Again, it was seen in patients who have oropharyngeal carcinoma. The laryngeal preservation data was presented as a poster maybe in 2008 ASTRO meeting or so. I'm not sure, but the laryngeal preservation comparing radiotherapy versus cetuximab, but that abstract was not published. So there is no difference between the two arms. Any questions? Combined cisplatin plus cetuximab, no role. Okay. No, because we cannot escalate beyond concurrent chemoradiation. There is no benefit by adding. Yes, I think I have one more question. Okay, that's a very good question. If CDTP is contraindicated, which drug you prefer, sir, cetuximab or carboplatin? That's a very good question. Okay, to be very honest with you, okay, if a patient is, that's how I take it. Cisplatin, if the creatinine clearance is more than 60, you give full dose. But if between 30 to 60, the standard dose is to give half dose cisplatin. If the creatinine clearance is less than 30, the cisplatin is contraindicated. So that's a standard teaching. So in this situation, will you use carboplatin or will you give cetuximab? I do not know because there is no data. Okay, in most of the situations, I prefer to give carbo rather than cetuximab because the cetuximab only few people can afford. Okay, so if a patient, if you look into a situation like the Bonner trial design where an oropharyngeal primary with a T1 to T3 primary with a node positive disease, patient have a renal impairment, patient can afford, and the main concern with the Bonner trial was the patient, the benefit was mainly confined only to patients who received the axial radiotherapy with concomitant boost. So if you use a conventional radiotherapy, whether I can extrapolate that subset analysis and give cetuximab, I do not know. So I generally prefer carboplatin rather than giving. Yes. Hyperfractionation or conventional radiotherapy plus cetuximab. Okay, there is no data because there is no data because they have used, many people have used axial radiotherapy. If you look into the RTOG 0522, is RTOG 01. So they have used the axial radiotherapy. Or if you look into the panitumab, but there is no data to use a monoclonal antibody in addition to hyperfractionation. Yeah, that's a very good question. Dr. Suresh Kumar, is there a role for a gefitinib along with the radiotherapy? That's a very good question. Okay, if you look into the data for the TKI, along with the radiation in locally advanced head and neck squamous cell carcinoma, the data is mainly confined to phase 2 trials. The gefitinib data from Singapore group published in Annals of Oncology in 2012. That is chemoradiation plus gefitinib. We were also part of that international trial. Second is to use a lapatinib. And this data was presented by Professor Kevin Harrington, published in European Journal of Cancer in 2012. And if you look into the erlotinib data, that is also published in 2013 in JCO. And all the 3 trials, all were phase 2, all were negative. And this didn't take up, there was no phase 3, apart from the lapatinib in the adjuvant setting. There is the lapatinib, the phase 2 data in chemoradiation, we were also involved in that. In the gefitinib and the lapatinib, we were included, but there was no benefit. So both trials did not show any benefit in the international trial. So as of now, we cannot say that there is a phase 3 data to give gefitinib, although it is much cheaper. It is also an anti-EGFR drug. And really works, and the mechanism of action it also is, but I do not know, there is no phase 3 data to give gefitinib. Yes. Okay, so these any questions? If you have any questions, you can send me to my email, or if you need any of the articles which I have discussed or which I have told you, which is not present in the PPT. So you can ask. Then I'm ready to share the slides. I'm ready to share the slides or the PDF of the articles. Okay, so thank you very much for your patient listening. I appreciate that. Anything from your side?
Thank you, sir, for that excellent presentation. So I thank all the participants. See you forward on the next session.
Thank you. Thank you.